Dr. Hopman is a board-certified pediatric neurosurgeon and associate professor of neurological surgery. He's a staff neurosurgeon at both Seattle Children's and Harborview Medical Center. He dedicates a significant portion of his clinical practice to the surgical management of epilepsy in children. His mission is to deliver the absolute best care to each and every child and do it with compassion and diligence. He's also working hard to increase our understanding and approach to neurological illness through a variety of research efforts and by collaborating with the incredible colleagues in the laboratory and at all stages of healthcare delivery. Dr. Hopman received his undergraduate degree from Muhlenberg College, then his MD from the University of Medicine and Dentistry of New Jersey, which is now called Rutgers Medical School. He went on to complete his neurological surgery residency at the University of California, Los Angeles. And during this time, he also completed a doctoral degree in neuroscience, studying the cellular neurophysiology of epilepsy and cortical dysplasia and tuberous sclerosis. Feel like a doctor after saying that sentence. He then went on to complete his pediatric neurosurgery fellowship at Children's Hospital of Pittsburgh, and he holds a certificate in the clinical trials from the University of Washington. And he is a much beloved neurosurgeon here at Seattle Children's. And with that, I will turn it over to you, Dr. Hopman.
I really appreciate the super kind and extravagant introduction. Thank you so much, Erin. For everyone on the call, my name is Jay Hauptman. I'm a neurosurgeon, here at the University of Washington, and I've really dedicated a lot of my career to thinking about and treating epilepsy in children. And we'll go through why a neurosurgeon could be necessary in treating children with epilepsy, and we're going to have such a phenomenal speaker that's going to join us at the end, a parent, a treasured parent of a patient of ours, Kanal. And I hope by the end of the talk today, we could at least cover why we do surgery for epilepsy, what those surgeries look like, and how we can benefit children by doing surgery for epilepsy. And I encourage any questions at any time. Please don't hesitate. And I'll just run through some slides, and please stop me if something isn't clear. Let's see if I can advance my slides. There we go. Great. I have some consulting work for these disclosures. None of it really bears anything on what we're going to talk about today. First and foremost, while I'm here speaking to everybody, really I'm representing a large group of people that work incredibly hard to take care of children with epilepsy, and they are all phenomenal, and they all work here at Seattle Children's. My partners, Dr. Ogeman and Goldstein, were the trio, the three musketeers of epilepsy neurosurgery. Our neurology team, genetics, neuropsychology, radiology, we have study coordinators, we have basic science researchers trying to uncover the mysteries of brain function in children. We call them the grid lab. We have terrific colleagues in pathology and even in oncology. And so thank you to everyone. And it really does take a village. So everything I'm going to tell you today really is representing the fantastic people I work with that I have the pleasure to help. These are the objectives today. We're going to talk about treatment refractory epilepsy. We're going to talk about why surgery. We're going to talk about what kinds of things we see in pediatric epilepsy surgery. We're going to talk about surgical options and then outcomes. Excuse me. So if we take it all the way to the beginning, epilepsy, what does it mean? What's the difference between having seizures and being diagnosed with epilepsy? The difference is the number. So after a single unprovoked seizure in a child, the risk of a second is approximately 40 to 50%. Once a child has had two non-provoked, meaning there's not a reason, a stimulus for that seizure to occur, non-febrile seizures, the chances of having a third seizure in the next few years is almost certain. It's about 3 out of 4, all the way up to 90%. And it's at that point that the child had two unprovoked non-febrile seizures that we consider diagnosing them with epilepsy, and we think about treating them with medication. And that's when my great colleagues, the neurologists, step in, and we'll start with medical therapy, medical evaluation, medical therapy for epilepsy. Where does the surgeon come in? The surgeon comes in when we reach a diagnosis of what we call treatment-resistant or refractory epilepsy. In general, if seizures are refractory to two anti-seizure medicines, the chances of additional medications effectively rendering the child seizure-free becomes less than 5%. We derive that number from a large natural history study that Quan and Brody did over 20 years ago in New England, where they followed children who were diagnosed with epilepsy and found that once a child had been on two anti-seizure medicines, adding a third or a fourth, and it didn't matter what those third or fourth were, the chances of those third or those fourth effectively curing epilepsy became less than 5%. We also know that if children have something on their brain MRI, something that could potentially explain why they're having epilepsy, the chances of additional medications helping is even lower. A lot of us in the field of pediatric epilepsy and pediatric epilepsy surgery truly believe that if we keep pushing endless medication trials beyond the two anti-seizure medicine limit or ceiling, that they're going to continue to have suboptimal seizure control, and that in the end, that could lead to some unacceptable neurological morbidity or even mortality. And that in and of itself is really the foundational justification for why epilepsy surgery. So as a strict definition, a definition that we apply to all children with epilepsy, if they have been on just two anti-seizure medicines and continue to seize, and if these two medicines are dosed correctly and they're tolerated, meaning kids aren't not taking them because of side effects, they are considered medically resistant, treatment resistant, medically refractory. Those are all synonyms that you might hear referring to kids who've reached that two anti-seizure medicine threshold. And with my great colleagues that have joined us on the call today, I would say that is the most important thing to take away from the talk today. Really identifying, early identification of kids who are treatment resistant is what's going to make all the difference in the world. If we identify these kids early and we refer them early to a comprehensive epilepsy center like Children's, their outcomes will be better. They'll be more aggressively managed. They'll be thought about for surgery earlier, and their developmental outcomes could potentially greatly benefit from that. And because my pediatrician colleagues are really out there on the front lines, seeing children regularly, seeing children with complex medical conditions regularly, you are in fact arguably in the best position for early identification of these children. If you're seeing kids in clinic who maybe you're not even seeing them for their epilepsy, but you note that they're on 3 anti-seizure medicines, it would be reasonable to think that they might be treatment resistant. And it might be worthwhile to ask them if they would like a referral to a quaternary epilepsy center like Children's, where we can do a comprehensive epilepsy evaluation. Especially with the national shortage of pediatric neurologists, our pediatricians are really doing the hard work, seeing these patients with complex medical issues, and many times are their only medical point of contact, particularly in rural and underserved areas. Adding on to the 2 anti-seizure medicine failure definition, a newer modification to that definition has been if a child has a positive brain MRI. So they get a brain MRI and they have something like a cortical dysplasia or a low-grade tumor or some other developmental malformation. If they have a positive MRI and they've failed one drug, one anti-seizure medicine, they're actually considered treatment resistant. And I'll show you a graph later that kind of shows that in a Kaplan-Meier form. But essentially, the likelihood of seizure freedom after one drug in children who are MRI positive is incredibly low. And so we entertain early seizure surgery for those children in particular. When we think about seizure freedom, and this is tied into, well, how do I decide if a child is medically controlled? They're on medicine, they're not having seizures, or they haven't had one in a while. Are they seizure-free on medicine? The way we define that is a seizure-free duration that's at least 3 times the longest interseizure interval prior to starting the medication, or at least a year. So what I mean by that is if you have a child that's seizing every day and they're seizure-free on medication, you'd want to wait about a year before you call them seizure-free. If you have a child that seizes once a year, you'd want to wait 3 years before calling them seizure-free. And that's the semantics that we use to determine whether a child is medically controlled or medically resistant. So the incidence of new onset seizures in children is not small. It's approximately 4 in 1,000. And over 2 years, about 10% of these children will have treatment resistance. And if you look at the global population-based data, it could be up to 20 to 30% of all children diagnosed with epilepsy that will actually reach the definition of treatment resistance. Even in children who have medical control of their epilepsy in the first year of life, there's still a little less than 10% chance that their seizures will become refractory in a year. So it's a bit of a moving target. Even if a child initially looks like they're being medically controlled in the first year of life, there's still a 1 in 10 chance that those epilepsy medications will not cover complete seizure freedom. Like I was alluding to earlier, we know, based on studies that have been done over 15 years ago, that cases in which the MRI is positive typically are highly refractory, which is why we've adopted the one drug failure definition for kids that have a positive brain MRI. And what you're seeing in the lower right-hand side is the likelihood of seizure freedom if you've had a lesion or if you've not had a lesion. So you can see in the dashed line, which is the higher line, that's if your MRI is negative. If your MRI is positive, that's a solid line. So you can see that there's a significant drop-off over the first 5 to 10 years of seizure freedom if your MRI is positive. Why intervene early? Sometimes the foundational explanations for why we entertain surgery for epilepsy are super helpful for parents so that they can contextualize the idea of doing brain surgery with what their child has to gain from being seizure-free. We know from studies of kids with unilateral temporal lobe epilepsy that IQ dysfunction, intellectual dysfunction, low IQ less than 79, can occur in up to 60% of children who have uncontrolled unilateral temporal lobe epilepsy. We know that independent of pathology, intractable seizures during the first 2 years of life in all infants, intractable seizures is a significant risk factor for long-term intellectual disability. We know that if seizures are inadequately controlled early in life, that it may result in impairments in cognition, in language, in social skills, in communication. And if that goes on in long term, we call it the epileptic encephalopathy. And I'm sure that you've all seen children like this in your practice who are sort of globally impaired from long-standing epilepsy. It can sometimes even look like they're on the autism spectrum, even though it's a little bit different. We also know that suboptimal seizure control results in poorer psychosocial outcomes. We know in kids that have poor seizure control, they have lower rates of high school completion, lower rates of holding a job, keeping a job down, lower rates of marriage or other domestic partnerships, and overall socioeconomic productivity. And these are all drivers for why we think about surgery earlier. We know that early surgical intervention for intractable epilepsy can result in improved IQ scores. It can result in improved developmental indices across the board. Multiple studies have supported this. We know that most importantly, successful epilepsy surgery can reduce seizure-related morbidity and mortality. And this is a really key point. A lot of my parents that come and talk to me about epilepsy surgery, they're numbers people. They want to understand the risk of surgery versus the risk of ongoing epilepsy. And when I talk about, low IQ, developmental indices, developmental stalling, those kinds of things, they're a little abstract. So generally, I put it into context by talking about mortality secondary to epilepsy. Sudden unexplained death secondary to epilepsy, abbreviated SUDEP, S-U-D-E-P, is unfortunately not a trivial risk in children with intractable epilepsy. Most studies will suggest that the risk of mortality secondary to uncontrolled epilepsy is somewhere between 0.5% and 1% per year, and that it's cumulative. which is a tremendous risk of mortality secondary to what you might consider to be a benign childhood disease. That means that in 10 years, a child who's been medically intractable since infancy could have anywhere from a 5 to 10% risk of mortality from the epilepsy alone, which I would argue is an incredibly unacceptably high risk of mortality. Moreover, any surgery that we can do for epilepsy, any surgery that we can do has a risk of permanent morbidity or mortality that is lower than that SUDEP risk over the course of the childhood. No surgery that we offer would approach anywhere near that 5 to 10% risk of mortality over 10 years of living with intractable epilepsy, which is a really compelling numerical argument for epilepsy surgery. If we can mitigate the risk of mortality secondary to epilepsy through a surgical intervention, that's huge, especially when the risks of that surgical intervention are nowhere near the risks of uncontrolled epilepsy. There was a survey that was done now a bunch of years ago looking at how we were doing. What was the state of the field in epilepsy surgery? What we found, if you look on the left-hand side of the screen, that's the age at which seizures began in kids who were referred for epilepsy surgery. Almost half, more than half, were kids that had seizures that began in the first 2 years of life. But if you look on the right-hand side, that's the age at which they actually got surgery. And you can see in the histograms that the vast majority of them were late teenagers. So there's a huge disparity there. Kids who need epilepsy surgery, their seizures are starting really early in life, the first year or 2 or 3, but they're not getting to epilepsy surgery till the late teenage years. And so that's where the biggest impact can be made in epilepsy surgery, is early identification and early referral, taking these kids who are identified early in life as being medically refractory, getting that definition as quick as we can, and then referring them as quick as we can makes all the difference in the world, because it's the youngest children who have the most to gain intellectually, developmentally from not seizing. And so we have a mantra, the earlier, the better. And this is where we can improve as a field on the whole. These are some of the things that we see in epilepsy surgery. There's going to be a bit of a tour de force of neurosurgery. I'm just going to run over a few things. By far and away, from a lesional structural perspective, the most common etiology we see in epilepsy surgery in children is cortical dysplasia. Cortical dysplasia is essentially a disorganization of the cortex from a developmental origin. Nerve cells are turned around, they're upside down, their dendrites are employed in the right direction, the neurons can look abnormal or immature, and therefore they are electrically immature. And when they are electrically immature, that's what directly leads to epilepsy. Sometimes you can see cortical dysplasia on an MRI, but you can't always see it. So it's a microscopic diagnosis. We're trying our best to increase our ability to diagnose these non-invasively, and we've come a long way. But there are many times where the MRI is negative and we see the cortical dysplasia under the microscope. More severe cortical dysplasia will appear at younger ages. They're going to have higher seizure frequencies, and those are going to be kids that generally have cortical dysplasia outside their temporal lobe, which is fundamentally different than adults who get epilepsy surgery, where the majority of them are actually in the temporal lobe. Up to half of cases with cortical dysplasia, especially subcortical dysplasia, will be negative on MRI. One test that we found super helpful in trying to diagnose cortical dysplasia non-invasively is a PET scan. And that's looking at metabolism of certain brain regions. And if the metabolism is low, we suspect that region might actually be where the seizures are coming from. Focal cortical dysplasia in general is most likely going to be in the frontal or temporal lobes. This is the classification that's used, and this is based mainly on microscopy. We won't get too deep into that. Other etiologies, low-grade tumors like gangliogliomas and DNETs. They can sometimes even be with a cortical dysplasia, and these are incredibly great candidates for epilepsy surgery. High remission rates of seizure when these things are resected, greater than 80%. Other things, children who've had ischemic injury from early in life, kids that have what's called hippocampal or mesiotemporal sclerosis. That's the most common reason why adults get epilepsy surgery, but it's actually much less common in children. Then there are some of the rarer genetic entities. Sturge-Weber, many of you may have seen it in your practice. Those are kids that have a port wine stain over the trigeminal V1 distribution, and their brain is covered superficially in what we call peel angiomas or peel angiomatosis. And those kids can develop intractable epilepsy early on in life, which will then lead to developmental delay in stalling and a progressive hemiparesis. And hemisterectomy, which is a surgery we do to disconnect the hemisphere, is a very effective surgery to relieve these children of their epilepsy and prevent developmental stalling. Tuberous sclerosis, which I'm sure you've all seen before, is a genetic entity in which kids are predisposed to form, among other things, cortical tubers, which are hamartomas, and they're very commonly associated with both intellectual dysfunction and epilepsy, among other things. These are children who have a genetic predisposition to epilepsy, but may very well benefit from epilepsy surgery because we can give them sometimes very long periods of seizure freedom so that their brain can catch up developmentally and they get the most developmental gains. This is a rare entity, Rasmussen's encephalitis. It's a progressive autoimmune disease in which one hemisphere becomes slowly atrophic. And there are some things medically that we can do to treat and buy time, like steroids, immunoglobulins, and plasmapheresis. But surgical therapy, hemisterectomy, is the only cure that we really know of. And if any of you have seen that Netflix documentary, Diagnosis, it was like a multi-segment series on Netflix. The very, very first episode of Diagnosis was a child in New York who had Rasmussen's encephalitis and progressive intractable epilepsy, who was treated surgically. One of perhaps the rarest but most interesting entities that we see in epilepsy surgery is the hypothalamic hamartoma. That is exactly what it sounds like. It's a hamartoma in the hypothalamus, and it's characterized by a very unique form of epilepsy that we call gelastic epilepsy. And it's laughing fits that are not euphoric, laughing fits without mirth, and it can develop into other forms of epilepsy like generalized epilepsy. We do a novel surgical therapy called laser ablation for this, and that's actually revolutionized treating hypothalamic hamartomas. It's minimally invasive, and a lot of these kids go home the next day. It used to be that you'd have to do a large craniotomy, you'd have to go down in between the two halves of the brain and do an open surgery to disconnect the hypothalamic hamartoma. Now, we don't even shave hair. It's an incision the size of my pinky fingernail. And like I said, kids are like in the hospital for 24 to 48 hours and are home living their lives. So that's been the transformative therapy, hypothalamic hamartomas. We see probably one or two of those a year here at Children's, referred to us from all over the Pacific Northwest and sometimes the country, even occasionally outside of the country. Then there are even rarer entities, one of which we're going to hear a little bit about today. Hemimegalencephaly is like a cortical dysplasia that affects the entire hemisphere. And so the entire hemisphere is affected. Seizures can be catastrophic, very early in onset, and can really, really significantly impair children. The only way to approach hemimegalencephaly surgically is through a hemisterectomy. That provides the best chance of seizure control and the best chances of a great neurodevelopmental outcome for children. In order to get epilepsy surgery, it's really a team sport. We identify children early who have medically intractable epilepsy, we bring them in the system, and we basically have a ton of providers weigh in to help us figure out where in the brain the seizures are coming from. This includes our neurologists, our neurosurgeons, our neuropsychologists, sometimes even our psychiatrists. We're going to do scalp EEG, we're going to do MRI, we're going to do PET scans, we're going to do neuropsychological testing so that we can track these kids over time and look for areas of the brain that might not be functioning as well as they could. And sometimes we're even going to do surgery to figure out just where the seizures are coming from. Video EEG is exactly that. We bring kids in the hospital, we put scalp stickers on them, we keep them on camera, we wean them off their medicines so that we can not only see the behavior associated with the seizure, we call that semiology, but then we can see the electrical signature of the seizure, where in the brain we think it might be coming from. That's a non-invasive test, and it requires anywhere from a 3 to 7 day admission. We have our neuropsychologists see our kids. They do a wide variety of tests, spend hours testing our kids, trying to find different cognitive domains to figure out what part of the brain might not be functioning as well as it could. And also, so we can track our outcomes. So after we do surgery on children with epilepsy, if we need to do a brain surgery, a brain disconnection, we can see how much better or how much we've changed this child. Structural high resolution MRIs, what we're doing now is routinely is a 3 Tesla MRI. The world may at some point move to 7 Tesla. And that's helping us see with a greater degree of granularity brain lesions that we've never seen before. The PET scan, which I alluded to earlier, which is honestly an incredibly beautiful scan to look at. It's color coded according to the amount of metabolism that the cortical surface is engaged in. In between seizures, areas that cause seizures actually are cold on PET. They're hypometabolic. If a child has a PET scan while they're having a seizure, it's incredibly hot. Those neurons are working in overdrive. But in between those seizure events, it's like that area, they're tired, they're sleeping, they're hibernating, and they look cold on PET. And over half, and sometimes up to 75% of cortical dysplasias can be identified by looking cold on PET in an interictal or in-between seizure fashion. Sometimes we'll send kids to Harborview to do a special study called a SPECT scan. A SPECT scan is the opposite of a PET. You want to catch them while they're having a seizure. You give them an injection of a radionuclide that gets taken up by the areas that are actively seizing, and as soon as they have a seizure, you put them in the scanner, and the area that's causing the seizure will light up bright like a light bulb. That can be really helpful in kids who have more than one lesion, like tuberous sclerosis, where they may have multiple tubers, so that we can figure out which is the one that we need to remove, which is the one that we need to disconnect to potentially render this child seizure-free. There are a whole host of surgical approaches, and they've changed a lot even over the years I've been in practice, so that we can help more children, and so that we can do it less invasively with shorter hospitalizations, shorter pain, and less blood loss. When I started in my training, if we wanted to pinpoint where the seizures were coming from on the brain, we had to take children to the operating room, do a very large surgery where we exposed half the skull, removed half the skull, put a strip of electrodes on the brain surface, what we call subdural grid electrodes, then put the skull back, put the skin back together, and keep the child in the hospital while they have seizures, and we try to map them to those subdural grids. You could imagine it's a huge undertaking. You couldn't do it on young children because they would never sit still, and there was a big recovery. You're doing a big craniotomy and a big recovery just to find where the seizures are coming from. In the last 5 years, we've adopted a minimally invasive approach called stereo electroencephalography. We use a robot, we call her Rosa, and using incisions the size of my pinky fingernail and using a patient's MRI, the robot allows us to very precisely place tiny electrodes in the brain tissue. The recovery is incredibly fast, almost no blood loss. There's no hair shave. There's almost no pain. And the recovery after you take the electrodes out at the end of the hospitalization is a couple days, as opposed to a couple weeks when we were doing subdural grid electrodes. Once we figured where the seizures are coming from, if it's an area that we think we can safely remove or disconnect with a high probability of rendering the child seizure-free, we go ahead and we do that. On the small side of things, relatively, that could be removing or disconnecting a small area of the brain or a lobe of the brain, like the frontal lobe, the temporal lobe, the parietal lobe. On the large scale of things, if the entire hemisphere is affected, we would do something called a hemispherectomy, and I have a slide about that later. Other newer techniques that we've been involved in are neuromodulation, which are now implanted computers, implanted pacemaker devices that help us reduce the intensity reduce the frequency of seizures. They don't necessarily cure, but they make a whole lot of kids' lives better, and they make a whole lot of parents' lives easier. We'll get into that in a second. And then another technique called a corpus callosotomy, which we'll get into too. And we're now doing that minimally invasively. It's not, the same corpus callosotomy that surgeons were doing in the 80s and 70s. This is what stereo EEG looks like. What you're looking at on the left is a picture of a child who has stereo EEG electrodes in. Those are what those incisions look like. They're tiny. Notice we didn't shave any hair. It's a huge improvement over the subdural grid electrodes. On the right-hand side, you're looking at a map. That's a map of how we plan where we want to put those brain electrodes, and then based on the patient's MRI, precisely putting the electrodes in that area so we can study exactly where those seizures are coming from. This is the old way, and I'm sorry for the graphic image. This is looking at a child who needed subdural grid electrodes, and you can see the big difference between stereo EEG on the left and subdural grid electrodes here on the right. What you're looking at on the extreme right side of the screen is that craniotomy, that dural opening, putting those silicone grid electrodes on the brain surface and then studying where they're coming from. On the left-hand side is the result of the subdural grid electrode study, mapping the seizures, determining what area of the brain they're coming from, and then disconnecting that area with the hope and intention of rendering that child seizure-free or curing them. Perhaps the most successful form of lobectomy is the temporal lobectomy. And there's a landmark New England Journal of Medicine study that's now old. I think it's over 20 years old now, in which they actually did a phenomenal trial comparing medical therapy to surgical therapy. And what you see in the Kaplan-Meier curve to your left is that patients who had temporal lobe epilepsy, who were refractory and had the temporal lobe lobectomy, had an exponentially higher chance of not only becoming seizure-free, but staying seizure-free than medical therapy alone. And that landmark study has really helped us bolster the foundation of why we do epilepsy surgery. That's what a temporal lobectomy looks like on the right-hand side. Sometimes the seizures are coming from outside the temporal lobe, like in this case, this is a cavernous malformation, a left frontal cavernous malformation in child medical intractable epilepsy. We can just go ahead and remove that cavernous malformation with a high likelihood of rendering the child seizure-free. Sometimes, when areas of the brain that are super important for function, speech, understanding speech, producing speech, or movement, or sensation, and we want to preserve those areas, particularly in adults and older children who might not recover from a deficit, we do awake surgery. And here at Children's, we've actually spent a lot of time perfecting awake surgery in children, which is something not a lot of places do because it's a little bit technically more daunting than doing it on adults. What that's allowed us to do is it's allowed us to focus on doing surgeries to preserve function. Because to us, it's only a win if we cure the epilepsy and give the child back to the parent in the same condition that they gave that child to us. And that's what we go for here. And there are times where that's possible and there are times where it's not. But if there's any chance of us doing it, and if it means doing a surgery of the child awake to map out brain regions that are important in function and preserve them, we do it because to us, it's worth it for the best possible outcomes. I alluded to this earlier. This is laser ablation. It's super cool. It is some of the newest, most cutting-edge technology that we have in brain surgery, and we're adapting it to tumors and to epilepsy. It requires that robot, that same robot I was telling you about earlier, ROSA, for stereo EEG. That's how we do laser ablation. We pick an area of the brain that we think we want to ablate thermally. We make a tiny incision, no hair shave. We place the laser probe directly to that lesion. On the left-hand side, what you're seeing is a temporal lobe ablation for a child with mesial temporal lobe epilepsy. On the right-hand side, you're seeing one of those hypothalamic hamartomas I mentioned to you earlier in the child that had refractory gelastic epilepsy, laughing fits that were without mirth. In both of those cases, that color map that you're seeing is us in real time, while the child is in MRI, heating up that area of the brain to ablate it. And by doing it in real time, we're able not only to precisely only ablate the area we want, but we actually can in real time monitor the temperatures of all the surrounding brain regions to make sure that we're not injuring anything other than what we intend to injure, which is the area that's causing the epilepsy. The most dramatic surgery that we do, and the one we're going to hear about today, is the hemisterectomy. The reasons we do hemisterectomy are in cases of catastrophic unilateral hemispheric epilepsy. This is going to be kids with Rasmussen's encephalitis, cortical dysplasia or hemimegalencephaly affecting the whole hemisphere, Sturge-Weber, or large hemispheric migrational abnormalities. Other reasons might be post-trauma or post-stroke. And essentially, these are all kids that have catastrophic unilateral hemispheric epilepsy. And it is by far and away the most dramatic surgery that we do with some of the best outcomes. Historically, the way hemisterectomy used to be done was you would actually physically remove the entire hemisphere. That's what you see on the left-hand side of this screen. Nowadays, we actually don't do it that way. We do something called a functional hemisterectomy, which is technically more involved, but the outcomes are way better. What we do is we remove the minimum amount of tissue necessary to disconnect one hemisphere from the other. You could imagine, as you recall from neuroscience, that there are some really big white matter pathways that connect one hemisphere to the other. The corpus callosum, the anterior commissure. And these are the areas that we target for disconnection so that even if that hemisphere is still there, those seizures can't go anywhere. They can't spread to the rest of the brain. It's like we're excluding it from the circuit. And there's some advantages to healing that the functional hemisterectomy offers. The anatomic hemisterectomy, which is where you physically remove the entire hemisphere, the control rates for seizures are really high, but they would have delayed effects, which are basically chronic bleeding on the good side. And over the course of a lifetime, that had a lot of deleterious effects on children's development and function. Another way that used to be done was just to kind of remove the cortex of the affected hemisphere, but it wasn't super effective. Now it's what we call the functional hemisterectomy. Moving on, callosotomy. I'm sure many of you have heard of callosotomy because it's been around for probably close to 50 or 60 years, and it was one of the first surgical interventions that was ever done for epilepsy. Nowadays, we reserve corpus callosotomy for kids that have atonic seizures or primary generalized seizures with rapid secondary generalization. These are mainly going to be kids who are diagnosed with Lennox-Gastaut. And as you might recall, atonic seizures are immediate, instantaneous loss of body tone. So these are kids that are sitting or standing, immediately lose complete body tone and fall. You can imagine they hit their heads, they have craniofacial injury, they lose teeth, they could require neurosurgery for like a subdural hematoma. It's really, really dramatic and really debilitating for kids and for their caretakers. The old way of doing a corpus callosotomy was to do a big craniotomy, split the two hemispheres, and then literally physically split the corpus callosum between the two hemispheres. Now, the way we did that laser ablation for the hypothalamic hamartoma, we use the laser to actually ablate the corpus callosum. And it's, again, tiny incisions, really fast surgical recovery, and it gets them on in their post-operative journey a lot quicker than the open surgery would have. Callosotomy is super effective for these drop attacks, over 70% improvement, with over half of these kids being seizure-free. Some of these kids will get what's called the acute disconnection syndrome, which fortunately is temporary, but it can be characterized by paucity of speech, sometimes some apraxia or hemiparesis, and some urinary incontinence. But the nice thing about it is it always gets better. Sometimes it takes time, it can take weeks or even months, but it gets better. And we encourage parents to think about callosotomy when their kids are having terrible atonic seizures, requiring them to go to the hospital, requiring them to get stitches, having them lose teeth, and so on and so forth. Finally, the last surgical techniques I'm going to cover are neuromodulation. This is cutting edge. These are brain-computer interface devices that allow us electrically to affect brain activity to reduce epilepsy. These are all the different kinds I have listed out here. I'm just going to cover a few real quick. The first is vagal nerve stimulation. Vagal nerve stimulation has been around for over 20 years. It is not a brain surgery, which makes it really appealing to parents who are very intimidated by the notion of a brain surgery. It's an incision on the neck and an incision on the chest. There's a generator that goes in the chest and wires that wrap around a big nerve that goes from the brain to the body called the vagus nerve. By stimulating the vagus nerve periodically, over 50% of children with vagus nerve stimulators will have a greater than 50% reduction in their seizure burden. So it won't cure their seizures. Only about 5% or so are seizure-free after VNS, but it's a huge, huge improvement in quality of life when they're having 50% less seizures. And it's a huge improvement for their parents to not have to take care of twice as many seizures as they were before. One of the great things about VNS is almost any child with epilepsy, it doesn't matter whether we think we can cure them or not, is a candidate for VNS. Any child with medically intractable epilepsy can get a VNS, and it can be a huge quality of life push for them. Some of the newer techniques that we're doing are brain pacemakers. One thing called the deep brain stimulator, another called a responsive neurostimulator. These are implanted devices in the brain tissue that pace the brain tissue to reduce epilepsy. Deep brain stimulation, which many of you may have heard of because it's been around for a long time for older folks with Parkinson's disease, can result in a greater than 50% reduction in seizures. It's a battery in the chest, 2 electrodes in the brain. We put it in a deep area of the brain called the thalamus, which is essentially a bottleneck for a lot of electrical activity coming from the surface of the brain. The newer technique is called responsive neurostimulation. This is an implanted computer in the skull that can actually read brain electrical activity and react or respond to it. So it's constantly monitoring electrical activity from the electrodes that we place in the brain tissue. And when it detects a seizure, it's providing a small electrical current to that area to abort the epilepsy. Some kids can get a 70 to 90% reduction in their seizure frequency with responsive neurostimulation. It requires us to do a brain surgery to put electrodes in the brain, and sometimes even to figure out where to put those electrodes in the brain can require brain surgery, but it can be very dramatically effective for a lot of kids. Newer techniques of RNS and DBS, where we're putting it in the thalamus, have allowed us to offer RNS to almost any child with epilepsy with a reasonably good expectation for seizure reduction. Not necessarily cure, but seizure reduction. And these are all the different ways that we're actively working on trying to improve our surgical approaches to epilepsy. We're looking at bringing care to the home. How do we detect seizures at home? How do we do more EEGs outside of the hospital? How do we automate all that? How do we reduce the amount of time spent in the hospital trying to get the workup for epilepsy surgery? And how do we figure out how we're doing after we've done it? These are all active things that are being worked on here at Children's. I'm going to close with outcomes. Everything I've presented you so far is what can we do? Now I want to show you how are we doing. And the good news is we're doing really well. Up to 80% of children can be seizure-free after an epilepsy surgery. There's a lot of ingredients that go into that number. Is the MRI positive or not? Do they have an epilepsy syndrome or a genetic diagnosis? Is the lesion in an area that we can resect safely? Can we identify where the seizures are coming from in the brain tissue? All of those ingredients are baked into the percentage of children that are seizure-free, but all comers, we're achieving really good seizure remission rates. We know that kids that have seizures come from the temporal lobe, they do really well in particular. And we know that after epilepsy surgery, if in the first 6 months a child is seizure-free, there can be up to a 95% chance that they'll maintain long-term seizure freedom. Game changer for kids who've had daily or even hourly seizures. Up to 50% of children who are seizure-free following epilepsy surgery can actually be taken off their anti-seizure medicines. And I'm sure everyone on this call knows that parents don't love the anti-seizure medicines any more than they don't love the epilepsy. A lot of these anti-seizure medicines have a whole variety of side effects: cognitive, sleep, behavior, impulsivity, aggression, weight gain, weight loss. There's a lot that goes into it, not to mention the cost of the anti-seizure medicines for some of our families, that getting them off that anti-seizure medicine is huge. We know that kids who have focal resections on very particular areas of their brain tissue, particularly kids with mesial temporal sclerosis or tumors or cortical dysplasia, have high rates of seizure freedom. We know that if the seizures are coming from both sides of the brain, we may not be able to cure them. We also know that when the MRI is negative, we still have a lot more work to do to figure out how do we cure more of those kids. And if the area that's involved is near an eloquent area, an area for language, an area for movement or sensation, depending on how careful we need to be around that area, if we need to preserve those areas, that's where like awake mapping and advanced MRI come in. We may not be able to cure all those kids if we can't remove all the abnormal tissue. But we push those limits with all the advanced techniques that we have for mapping the brain so we can spare important areas. Here's the key. Remember how I told you at the beginning that the risk of SUDEP can be 5 to 10% over 10 years? The complication rates of epilepsy surgery are nowhere near that risk of SUDEP. Surgical mortality is less than 1 to 2% for almost any surgery that we do nowadays, and permanent unexpected surgical morbidity is less than 5%. So you're talking about a couple years of intractable epilepsy, and you've already surpassed the risk of any surgery that we can do. In general, the risks of surgery are less than the risks of the natural history of treatment-resistant epilepsy. We do counsel families for certain areas of the brain. There are risks of things like visual field deficits or even transient weakness. But many times in young children, they have incredible capabilities of actually regaining neurological deficits through neuroplasticity. In babies who have a hemispherectomy, you would think that they would be hemiplegic for the rest of their life, but they're not. Because of neuroplasticity, they can actually reallocate sensory motor areas and language areas to the good hemisphere, which allows them to relearn how to move that affected side. And they do a tremendous amount even in the first year. We know that by doing epilepsy surgery and rendering children seizure-free, developmental quotients might improve. We know that the better they are when we get to them for epilepsy surgery, the better they will be, which is why early surgery, early referral, because the better they are when we evaluate them and treat them surgically, the better they can possibly be. We know that behavior, attention, IQ scores all improve after surgery. We know memory and executive functions can remain intact. And I think probably most important to the children themselves, better school performance, better social adaptation, higher feelings of self-worth, higher feelings of peer acceptance, higher likelihood of getting a job, holding a job, allowing their families to go back to work and to school, giving them greater feelings of self-worth and social competence. And one of the most compelling studies that's been done is looking at kids who've had temporal lobectomy and showing that their quality of life indices actually normalize to that of age-matched healthy individuals after 3 years of seizure freedom. After 3 years of seizure freedom, their quality of life is the same as their healthy age-matched controls. To me, as a pediatric neurosurgeon, that's what it's all about. It's all about letting kids be kids, giving kids their childhood back, freeing them from the burden of epilepsy so that they can enjoy their childhood, so that when they think back at their younger years, it's not scarred with memories of epilepsy, but instead it's memories of the good things, of all the experiences they had because they weren't having seizures. And with that, I will end. I really appreciate you guys letting me talk to you today, and I'm willing to take on any questions that you might have.
Awesome. Thank you, Dr. Hoffman. I don't think we have any questions right this minute, so I'm going to transition over to our second guest speaker, and we will, of course, have time at the end for questions as well. So let me go ahead and share our next slide. So I want to go ahead and introduce Kunal Jagtap. Kunal is originally from India, and he and his wife attended school in Dubai in the United Arab Emirates. They relocated to Washington State in 2016 and have grown to love this time of year. I think we can all resonate with that. They love the outdoors and try to make the most of the diverse trails that Washington State has to offer. As a family, they value quality time spent together, whether it's exploring the great outdoors, immersing themselves in a Netflix series, enjoying music, or finding inner peace through yoga. Kanal's daughter, Gianna, is a patient at Seattle Children's, and he is here to share their story. Welcome, Kanal.
Thank you, Erin, and good evening, everyone. Firstly, I just want to thank Dr. Hoffman for sharing all that information. Being a data scientist by profession, charts and data are right up my alley. So it is absolutely incredible to see some of those numbers and see how all these techniques have helped different epilepsy patients. And I also want to thank Seattle Children's for inviting me to share my family's journey with epilepsy and epilepsy surgery with you all today. My name is Kunal, and our daughter Gianna was diagnosed with epilepsy shortly after she was born. I'm here today to talk to you about how epilepsy has affected our family, the journey that we have taken to get here, and our experiences with epilepsy surgery. Starting off at the very beginning, when Gianna was first diagnosed with hemimegalencephaly, we were absolutely shocked and devastated, as you can imagine. We had never heard of this condition before, and we had no idea what to expect. We were told that Gianna's seizures were frequent and intense, and that they were incredibly difficult to manage. We spent what felt like countless nights in the hospital trying different medications to control her seizures, but nothing really seemed to work. Needless to say, it was a pretty difficult time for our family, and we were just feeling very helpless and super overwhelmed. We were constantly worried about Gianna's health and safety. We felt like we were running out of options and that there was nothing that we could do to help our daughter. But that's when we were introduced to Dr. Hoffman and his team at Seattle Children's Hospital. He explained to us that Gianna might be a good candidate for surgery to control her seizures. He helped us weigh the risks and the benefits. We were pretty scared and hesitant at first, but after learning more about the procedure and the potential benefits, we decided to go ahead with it. We knew that it was a risky procedure, but we also felt like we had no other choice. The surgery itself was a success, and Gianna has been seizure-free since. It has been absolutely life-changing for our family. We no longer have to worry about Gianna having a seizure when we're out in public or when we're at home alone with her. We can focus on her development and help her reach her goals. She is almost 2 years old now, and she still does not walk or stand yet. However, she can roll, she can sit independently, she's moving around in place, and she feeds herself with her dominant arm. And we are continuing to focus on her development towards her motor skill goals through therapy. Talking about recovery, the road to recovery was not easy for us. Gianna's surgery required a week-long hospital stay, and it was an extremely difficult process. We had to take time off work to be with her, and generally we had to just adjust to a new way of life. In all of this, we have learned to take it one day at a time and celebrate the small victories. Seeing Gianna smile, hearing her laugh, watching her grow and develop in her own time is what keeps us going. It is a constant reminder that she is not defined by her diagnosis, but by the love and support that surrounds her. Epilepsy is a complex neurological disorder that affects millions of people worldwide, and Gianna's case is no exception. It is a condition that requires careful management and attention. and outcomes can vary depending on the specific child and their diagnosis. As a parent, it is hard to see your child go through so much, and it is even harder to make decisions that could potentially impact their lives. But with the support of our medical team, we were able to make the best decision for Gianna, and we are seeing the results of that today. We just cannot express how grateful we are to Dr. Hoffman's team and the entire team's expertise and their support. I I just hope that by sharing our story here today, we can help other families that may be going through similar experiences. From a parent's perspective, it has been very challenging to navigate the medical world and learn about all the different options that are available to us. That is why events like this, where we can hear from medical professionals and share our own experiences, are so very important in my eyes. It helps us feel more informed, more empowered, and more connected to others who can understand our struggles. So I just want to thank you for listening to our story, and I wish you all the best in your medical careers. I'll pass it back to you, Erin.
Thank you so much, Kanal, for sharing your story and Gianna's story. We're so glad that she's doing so well and that our organization got to be a part of that, along with, I am sure, many providers out in the community, including pediatricians. So with that, we have wrapped up the formal presentation. We have some time for Q&A. We're happy to stay on as long as needed. I know some of you may need to leave. So as mentioned at the beginning, I'm going to go ahead and give you all the ability to unmute yourselves if you would like to ask a question. You are also welcome to type it into the chat box. And we can facilitate that way. I know if there are no questions from the audience, Dr. Hoffman, you had a couple that you thought might be worthwhile for our audience to hear some perspective from Kanal.
Yeah, while people are thinking about any questions they might have, Kanal, if I had to ask you, if you could go your future self, everything you know, everything your family has been through, and you've been through an incredible journey of recovery and healing and transformation. If the future Kanal could have been back to have talked to you at the very beginning when you guys were feeling overwhelmed, what do you think you would have said to yourself?
I feel that I would have said to myself to take it one day at a time. I think that is the most important thing, and also just take care of yourself. That was one thing we were told a lot by doctors, because unless you're taking care of yourself, you're not going to be able to take care of the person that needs you the most at that point in time. So I would say those two are the biggest takeaways, that if I had to go back in time and tell myself, it would be that.
And what advice would you give parents who have children who have seizures now, medically intractable seizures? What would be your advice to them as they're trying to, navigate the system and trying to take care of their children? What should they be thinking about?
Yeah, I think, as I said, it's different, right, for every child based on their diagnosis. So I would say do your homework, speak with different providers, get their insight on the different risks, the different benefits associated with going through with something like what we had to go through, which was the hemispherectomy, and just weigh those options. Data doesn't lie. So trust the data. Trust the expertise of the doctor that you're dealing with, and just hope for the best outcome.
Thank you for those questions and also for those answers. I still don't see any questions from our audience yet, so I will just go ahead and share that I have dropped a link to the evaluation in the chat box for those of you attending tonight. If you don't mind filling that out, we would very much appreciate your feedback. And we will stay on for another couple of minutes in case there are any additional questions that come up. You can feel free to raise your hand, put it in the chat box, or go ahead and unmute yourself. And then the last little bit of housekeeping I will share is another link that I am putting in here, which is we are actually doing another CME event on epilepsy coming up later in June. And that is based off of research in precision medicine for epilepsy. And so we'd love for you to join us if this is a subject matter you're interested in. That's going to be a fantastic presentation as well. So I still don't see any questions, so I think we may be okay. I just want to thank everyone for coming tonight, and a huge thank you to Dr. Hoffman and to Kunal and his family for sharing their story. This has been super enlightening and engaging, and we appreciate your time and as well as the time of all of the attendees tonight. So thank you all so much.
And if I can leave all of our practitioners with the idea that if you have any questions, if you have children in your practice who you think could benefit from an epilepsy surgery consultation, or you don't even know whether an epilepsy surgery consultation is the right thing to do, we are more than happy to field those questions for you. You can contact us directly. You can call us in the neurosurgical offices. We're here to help. You guys are on the front lines doing really hard work and multitasking and managing lots of kids with complex medical conditions. If there's anything that we can do to make your job even a little bit easier, we're here for you. And thank you so much for coming.
Thank you all and have a good night.
Thanks for having me. Have a good night.